what actually happened, this does really reflect the need for automation and technology in the healthcare system. So good luck and thank you.
Thank you, Victor.
Thank
Okay,
you very much.
if we want to be on time, we have to move on to our next speaker, which is actually Nadine.
Thank you.
So I am going to give you a brief biography so you get to know her better. Nadine Ziad Zeinab is Oncology Pharmacy Unit Manager, Pain and Palliative Pharmacist, Ethics and Research Committee member, and Medication Safety Group member at Clemenca Medical Center, affiliated with Johns Hopkins Medicine International. With 7 years of experience in oncology pharmacy practice. An active member at the European Society of Oncology Pharmacy and part of the educational board at European Specialized in Oncology Pharmacy. Completed the following certificates. Clinical Pharmacy Virtual Internship course at Children's Cancer Hospital, Egypt. ASHP Pain Management Certificate, ISMP Medication Safety Certificate, ASHP Clinical Skill for International Pharmacists, and a Masterclass Certificate, Pharmacy Services on Cytotoxic Drug Preparation and Safety and Safe Handling. Clinical Oncology Pharmacy Service. Completed Masters in Pharmacology and Therapeutics at the American University of Beirut by 2013, and a Bachelor's in Pharmacy at the Lebanese International University by 2009. Her title of presentation today is Pediatric Cancer, a New Approach in Care. Okay, Nadine, I can't see you anymore, but if you are here.
We lost her. I think she will be joining again.
Yes?
I think she will be joining again. I think there might be some problem.
Okay.
Yeah, she's joining.
Okay. Busy day in nursing webinar today. We never had this much participant in one day.
Hello, Nafisa, can you hear me?
Okay,
Yes.
if you're ready, you can share your screen and start your presentation, please.
Okay,
Thank you.
Thank you for the biography. I'll start by sharing the screen.
Okay. Okay, we can see your screen now.
Okay, great. So let's start.
Okay.
Okay, so good afternoon to everyone, and I'll be presenting now a topic that's actually just a correction for the biography. I'm a former unit manager at the Munso Medical Center, and hope you can hear me well.
Yes, we can hear you.
Okay, so we'll go over the objectives. We'll try to provide an overview initially on pediatric cancer, what are facts to know, the symptoms which are really common, the types and available treatment modalities. And then we'll speak of a bit of the literature review and go over the integrated approach of cancer care that will lie the foundation of a new perspective in cancer care with the aim of providing optimized, personalized plan of care, supportive and palliative care, safe and effective treatment outcomes, so to improve the quality of life and quality at end of life. Finally, we'll go to discuss a bit of quality care evaluations of pediatric cancer, which is really also important. So as per the WHO fact sheet that was issued in February 2021, each year we have around 400,000 children and adolescents of the age 0 to 19 years are being diagnosed with cancer. And what makes it worse is that in high-income countries, more than 80% of the children have a cure rate versus only 15 to 45 in low to middle-income countries, which does really reflect a global healthcare inequality distribution in the care of the pediatric cancer. So improving outcome is still based on a very rapid and correct diagnosis, on an evidence-based therapy that has to be used, and patient-tailored supportive care. Based on the following and based on the inequality in the providing of care to pediatric cancer, in 2018, the WHO launched a global initiative, and this initiative was actually under the hashtag of Cure All strategy, and the aim was to achieve at least 60% survival for all children with cancer and to reduce the suffering globally by the year of 2030. So despite the advances currently in the treatment of pediatric cancer, cancer, and despite that there's an increase in the 5% survival of many of the pediatric cancer, yet pediatric cancer is considered a leading cause of death in pediatrics. The symptoms are really important to be educated on, and this is especially during the awareness during Pediatric Month, Pediatric Cancer September Gold Month, which is important to educate the parents on these symptoms, since most of these symptoms represent common illnesses that occur with the children during their daily living. So as you can see, they are grouped under the acronym Child Cancer, which is provided by the Pediatric Oncology Resource Center. So if we go to check the five top ranked cancers, pediatric cancers, and the symptoms associated with them, you can see that they're really common. For example, with the acute lymphoblastic leukemia, we can have bone and joint pain. We can have also a bleeding. For example, with the brain tumors, we can have the headache, the nausea, the vision problems. With the lymphomas, we can have the night sweats and the weight loss. As you can see, the persistency of these symptoms and the education of the parents so they can be able to detect these symptoms and refer them to their pediatrician is really important. Pediatric cancer does differ from adult cancer, so we have different types of cancers and different types of cancers. With the leading cause of pediatric cancer was the acute lymphoblastic leukemia, but with the advances and better understanding of the cancer genomics and the development of treatment, especially with the targeted therapies, now brain cancer is the leading cause. Well, the survival would tend to depend on several factors. Depends on the type of the malignancy and depends also on the childhood age group. So in certain types of gliomas, you can have like less than 1 year survival after post-diagnosis. For example, in metastatic sarcomas also, or sometimes in Wilms tumor in adult children, you can have less than 5 years survival. So what are the treatment modalities available? Treatment modalities, chemotherapy is still the cornerstone treatment modality for pediatric cancer. Add to this, as we have said, with the advances in the therapies and the treatment, we have targeted therapies that can be administered either as oral and parenteral. Along with this, we can have radiotherapy, surgeries, CAR T-cell, and stem cell transplantation. We can see, for example, that the addition of imatinib, which is a tyrosine kinase inhibitor for patients with acute lymphoblastic leukemia, has resulted in a increase in the event-free survival and also decrease in the percentage of acute lymphoblastic leukemia children. Moreover, the advances has also led to development of better drug formulations. For example, now we have liposomal formulations that can be better targeted with even less side effects and toxicities. So before going to map our flow chart of a new perspective in cancer care, I'd just like to highlight some of the literature that I crossed over and does mention an integrated review or an integrated approach in pediatric cancer care. So we can see that one of the review articles was in New Trends and Recent Care Approaches in Pediatric Oncology. And actually the review article did tackle new trends, which can be family-based, technology-based, child-based, non-pharmacological therapies, and program development programs. These all have been integrated to develop an evidence-based treatment plan in pediatric cancer. So we're starting to look outside the circle of a multidisciplinary care in the management. Another interesting article was the Advancing a Comprehensive Cancer.
Hello, Nadine. Okay, we lost you. If you can hear me, we can't hear you. Okay, let me tell her.
Hello.
Yes, you can hear me again, right?
Yes,
Yeah.
we can. Yes.
Sorry for the connection issues. We'll share the slide again.
Okay. Do you want me to show your slides so you can,
I think we're fine.
Okay.
Oh, okay. Thank you very much, Nafisa. So one of the integrated approach and care paradigm that's important to mention is the two trends in nursing that we have discussed previously. You can see that these trends would tend to intercalate together to form an evidence-based approach in care. So family-based care, where the families have the right to be educated properly on pediatric cancer, the side effects of the medication and the treatment plan. Along with that, a technology-based care where using smartphones or even technology-based applications, you can have educational videos or even automated surveys that can follow up for compliance of the children and patient satisfaction, program development that would set the clinical steps that have to be implicated in setting the pediatric cancer care treatment. Primary childcare, it's really important to be able to engage those children back into the society because they have to lead a normal life. And this is why also we have survivorship programs that would monitor for the late-term consequences of the chemotherapies and for the follow-up. Even healthcare providers, healthcare providers have to be confident when managing pediatric cancer so they can be able to provide optimal care with confidence. Okay, can you see my slides, right?
Yes.
Oh, okay.
Yes,
So
we can.
yes, so another part of the integrated approach in care is the having a development program of pediatric cancer. So once we have to have patients managed for pediatric cancer, then we have to have an adequate program being developed, which would involve the clinical skills that have to be used and the steps of managing those patients, as this would involve the appropriate education, psychological support, symptom and palliative care, home visits and consultations, and even caring for the psychosocial state of the children. This is actually the comprehensive quality care, cancer care trajectory, and which is really important because this can be because it can set standards to be advocated and which can be tailored to each country's social, economic, socioeconomic status to decrease the discrepancy in the care of pediatric cancer. Because the trajectory provides a puzzle that is linked together, where you have the cancer-directed treatment care. Along with that, you have to provide appropriate supportive care, whether symptom management and psychosocial, caring even for the quality of life and end of life, and even the bereavement, and even the survivorship program. So education is one of the most important thing that all healthcare members enjoy in doing, and providing education is something really important. However, the flow of providing the information and the type of the information has to be sequential in a step-up approach and in a coherent fashion. And this is actually what the family or caregivers of the pediatric cancer do seek. And based on a collaborative work of the oncology cancer group nurses, there has been set a checklist. So it's really important to have a checklist for providing information, to have a documentation of this information, and to have an assessment of the barriers or the boundaries to appropriate education of the parents. Parents feel that they are really responsible to take concise and wise decisions on the behalf of their children. So it's the right to get properly educated and informed of what is happening and what comes next and where are the available options. Pharmacist interventions in preventing medication error. Well, medication safety is something really important, especially when dealing with vulnerable population as the pediatric population on one side, and when dealing also with high-risk medications as cytotoxic medications, for example, the chemotherapy medications. So it's really important that in a study where pharmacist interventions were assessed in the prevention of medication errors, as you can see, there were top 3 interventions that were made by the pharmacist, and these interventions were providing adequate drug information. There have to be adequate drug information provided, and also the utilization of evidence-based resources and updated to provide the following information. Another intervention was also the drug therapy changes, which were made based on dose adjustments according to the dose tailored to children. And also we have taking medication history appropriately and counseling, because you know that these patients would be on multiple medications upon admission to hospitals and discharges, which can be used to manage their side effects as nausea, infections. So it's really important to have a good history of medication taking. Add on top of this that parents would tend to overload their children with supplementary and herbal and vitamin stuff, believing that they would tend to boost their immunity. So pharmacists should play a good role in clarifying the safety of these medications and how to use them properly. And among the top 3 errors that were actually reported was also the inappropriate dosing, the need to dose adjust and dose reduce, and labeling errors, which requires a double check and a verification system, or even the use of a computerized and automation system. And also one of the errors was an untreated indication errors, where sometimes the children required extra medication so they can be able to manage for a certain side effect or prevent a certain side effect. So mapping our new approach in pediatric cancer care will involve a vicious circle of development of an adequate treatment plan of care, palliative care and symptom management, personalized medicine, medication safety is really important, and then quality assessment and improvement. So the plan of care would involve setting the appropriate protocol for the treatment and the roadmap, because sometimes pediatric cancer can take a lot to go into the induction and the remission phases. So you can see that multiple groups have integrated together and they have pulled into what we refer to as the Children's Oncology Group to avoid the redundancy in the sharing of the information among the region. And finally, the Children Oncology Group would provide evidence-based information, and also it links that to the National Cancer Institute under the Pediatric Division. Other also authorities or acting bodies that can be used as references for providing evidence-based references on the treatment plans and even educational material. We have the International Society of Pediatric Oncology and Childhood Cancer International corporate groups. We have, from these we can extract our treatment roadmap, set the protocols, and then apply the following in a multidisciplinary approach of care. So the treatment plan would involve the assessment of the disease and the staging, because treatment would differ accordingly, and then setting a treatment protocol and implementing that protocol. It's important to move into a step also of parents' education, reporting of the side effects, and the monitoring. Safe handling of oral and neoplastic. Part of the treatment would involve parents administering medications at home, which would require educating the patient on the safe handling of cytotoxic medications, especially with the siblings around and elderly population also living around. Tools for tracking compliance is really important. Sometimes the pediatric may vomit, they may skip a dose, so it's really important to be able to track this compliance and see how to increase that compliance to the medications. Encouraged to participate in clinical trials and guide it through, and of course, follow up on survivorship programs also. So what are some of the clinical bedside challenges that anyone can face or across? First of all, we're dealing, as we have said, with the pediatric population, and pediatric population, there are not many adults. They are a high-risk population. So it's really important to be cautious at all levels, from the diagnosis, administration of medications, management, and throughout all the process of the treatment plan. Then the medications. Medication managing in pediatric is really challenging because, first of all, it requires an appropriate dosing based on the body surface areas and the renal hepatic function of those children. Sometimes you may need to formulate the drug in an extemporaneous formulation so children can be able to use the drug in a liquid form per se. The administration and adequate dilution is also really important. Home medications and discharging supportive therapy, providing clear information to the parents, is also important, so that to prevent complications that can result from the treatment. Patient and family education, it's really important, as we have said, to provide adequate, appropriate education, documenting of this education also. Symptom management, because along with the treatment plan, we can have other cancer-related and drug-related side effects, which have to be managed by a palliative and symptom management team on board. Clinical aspects, as we have said, as the safe handling of oral hazardous agents, the portacath placement, we should have an adequate also staff competency and education so they can feel confident while handling pediatric patients. Palliative care and symptom management. Well, the WHO report states that on cancer pain relief and palliative care in children, to support the implementation of palliative care at times of diagnosis and irrespective of the outcome. Well, the palliative care team would allow appropriate symptom management, would aid the family in appropriate and help them, guide them through or support their decision-making process, even the bereavement phase, provide also adequate information that can be needed and how the family can cope with the conditions they are living, or how the child also can cope with his cancer, providing also psychological impact and symptom control. So among the symptoms that a palliative or symptom management team would manage, for example, the anorexia, bleeding that would tend to occur, sometimes sores, bed sores, psychological support needed, the pain sometimes also. Personalized medicine, as we have said, there's a better understanding nowadays of the tumor genetics and the tumor biology. So we're moving into what we refer to as a precision medicine, whether at the level of the drugs that have been used, the targeted therapies, or even the pharmacogenetics for appropriate assessment of the medication. So we do not have side effects or sub-therapeutic or over-therapeutic side effects. Pharmacogenetic, for example, consideration, one of the examples is for those that have a TPMT. And the multi-15 decreased activity, they would have fatal myelosuppression when using one of the medication, which is 6-mercaptopurine, and therefore the drug is redosed again based on the enzyme activity level. And also we have therapeutic drug monitoring of certain medications as with the asparaginase, because we have different formulations, and therefore therapeutic drug monitoring would allow to administer the adequate dose, therefore preventing any hypersensitivity, infusion reactions, or even antibody inactivation of the drug, which occurs later within the treatment. Medication safety, unfortunately, if you surf the literature, you would see low reports, or there are not much reports on medication errors being reported. Still, we live in a culture where reporting errors is considered a taboo. So this is why we should start with having an adequate environment or culture of reporting errors, an adequate system to report these errors, and also how to analyze these errors to provide a risk mitigation strategy that can decrease future errors from occurring. Pediatric patients are at a threefold increase in developing errors compared to the regular population, and this would stem because of a not fully developed hepatic renal metabolism of the medications, because also of the inability to express certain side effects or consequences. So it's really important that there have been a lot of best practices and acting bodies as the Institute of Safe Medication Practice. These acting bodies do support certain standards or best practice that can decrease the medication errors. For example, we have to standardizing the metric measures and nomenclatures, expressing the doses and concentrations per body weight, double order verification for such populations, the use of smart pumps when administering chemotherapy medications, or even having drug libraries for high-risk drugs. Reporting and risk medications is really important, so we can be able to decrease errors and prevent them from occurring. So it's not important who did the error, but important why and how we can prevent that error again. So we all know this, that you cannot control what you cannot measure. So implementing a pediatric cancer program would require a quality assessment of what has been implemented for better improvement, and also for existing as a teaching tools for better development of this quality of pediatric cancer care. Indicators have been, a lot of indicators do exist, but although not frequently being utilized, but we have, for example, counseling, the percentage of the amount of counseling that's being performed to the parents for the appropriate use of the medication, how much of medication errors in the pediatric hematology oncology occurred, integrations of palliative care since the time of the diagnosis of the pediatric children with cancer, central venous access infections, and also the ICU admission post-neutropenia, so the time of ICU admission post-neutropenia. So thank you for listening, and those are the references.